Good morning. I'd like to talk to you about a project that Eve and I have been engaged in recent years, applying machine-based learning to improving evidence-based best practice in clinical medicine. We're going to talk about chronic conditions, often called non-communicable diseases in the worldwide vernacular. But about 59% of U.S. population has chronic diseases. They account for 90% of U.S. healthcare costs. And there's a subset of individuals, about 28%, with 3 or more chronic conditions that account for about 2/3 of U.S. healthcare costs. So healthcare costs are driven in large part by these chronic diseases. Virtually every chronic disease has an evidence-based guideline, which is often 100 to 300, 400 pages long. It's been estimated that it would take clinicians nearly 22 hours a day to implement the evidence-based guidelines for the patients they see each day. And that's just not possible, and I think is part of what contributes to clinician burnout. So what we're really looking for are those modifiable variables that drive substantial variance in outcomes of interest, and then simplifying the number of things that clinicians are asked to do. A limited number of chronic conditions drive a disproportionate share of costs, certainly diabetes, cardiovascular diseases, which we'll be talking about, cancer, chronic kidney disease being other major contributors. And again, the opportunity to be able to do analytics to identify these drivers of variance in outcomes to simplify cost and simplify care is a major issue. This is a ranking of some of the most common chronic diseases in the U.S. population. You see hypertension, which we'll be talking about at the top at 27%, but lipid cholesterol disorder is also very common, diabetes, which we'll also be talking about. Now on the right-hand side, what you can see is that these individuals at the top, these folks with 5 or more chronic conditions driving 41% of U.S. healthcare costs to 28% driving 2/3 of U.S. healthcare costs, and then individuals with chronic diseases associated with 90% of U.S. healthcare costs. So a major driver of our escalating healthcare costs in this country, which we know are unsustainable. Interestingly, while this drives most of cost, our U.S. healthcare system has not been designed to take care of chronic disease, particularly the patients with multiple chronic conditions that drive most of the cost. We're very good at addressing acute health problems and life-threatening trauma, and we do reasonably well in patients who have a small number of chronic conditions. We're relatively efficient at primordial prevention, preventing hypertension, diabetes, obesity in the first place. We're relatively ineffective behavioral health, depression, alcohol and drug abuse, and we're really efficient with multiple chronic conditions. We have ineffective public health, we have limited public health funding, and then we have siloing of primary care, behavioral specialists, and the specialists so that a patient with multiple chronic conditions can't get integrated care at one point in the system. So the objectives here are to improve the quality and timeliness of care, enhance the financial performance of the system, and decrease practice variation, particularly increasing consistency with good practices. Again, identifying critical processes, interventions that drive these outcomes so we can focus our time and resources on those factors that drive outcomes. Implementing insight in evidence-based care to enhance the quality of care, the effectiveness of care, the consistency of care. And then the typical academic training cycle takes 5 to 15 years. There's discovery, it's slowly translated, we learn results over a period of time, and 5 to 15 years later, we can drive another cycle. What we really want to do is to accelerate this cycle with timely and real-time analytics. And then being able to predict what drives good outcomes, including the community and social determinants in the equation. So this is a multidisciplinary team. Georgia Tech, Dr. Eva Lee with the Analytics, our Care Coordination Institute, is currently actually working with more than 737 clinics. And you see Grady, University of South Carolina, Morehouse have also been part of this collaboration. And then Georgia Tech, the Center for Operations Research. The scope, our database that we shared with Eva includes 2.7 million patients. It covers a significant time span, multiple sites, nearly 9,000 clinicians, and includes the data that's shown here. And at this point, Eva, I'd like to turn it over to you. You got a big database from us, and you had a lot of diseases to look at. So let me take a step aside.
So we are really grateful in terms of really getting the data. And one of the things, and one of the real challenge in healthcare, as many of you here has done healthcare research, is that realizing it is really difficult and have to find evidence in data and being able to give it to the doctors. But it's how do you actually even use those data in the most effective way? And how do you actually use data? I remember we always complain about not having data, we get the power. But I remember one of the colleagues mentioned he spent 3 years just trying to get data from one single hospital. So I am really grateful the fact that we are able to do this project. Everything is because of Dr. Agan. And we spent 9 months just to get all the data together. And so how does that work? First, we have to really connect all these pieces of data together. Because even within a single site, as a doctor, they write differently, they prescribe differently. How do you actually put all these terms in standardized form using the standard clinical terminology, which is the SNOMED-CT, and connect all these information. And now, once you connect them, you have to extract what are the key features there. So we always like to say big data, but within big data, some data is more important than the others. So we want to be able to really extract those key ones. And I think like if you ask a doctor to change 1,000 steps in order to achieve the outcome that you say is going to achieve, it is not feasible to do that. So how do you extract those data? How do you clean up those data so that you can actually analyze it and put it into our models? And I think OR is so dear to us, all the analytics people, is that what we have power is the mathematics and the model itself. If you cannot fit it into the model and it does not work, then you don't really have anything to start. And then we try to cluster them, trying to figure out what are the best practice. And the clustering itself is that the doctor, well, this is a good idea, but this is individual practice, right? So they have lots of ideas based on their practice. How can we actually looking at it cumulatively of all these patients from over more than 737 sites now, is that are there any patterns that we can find that are common? This is very, very important, and not just for clinical practice, but for many practice. Then we do machine learning, trying to extract. Now we know there are clusters, there are best practice, there are bad practice, there are some that doesn't give you really good results or bad results, it's just fluctuating, so patients are not improving, but yet they are not also getting worse. And then we do machine learning and trying to select the smallest amount of features out of that, so that that would give us an opportunity to really implement it into the clinical setting. And then we do blind prediction. Once we extract those and we have the classification rule, we want to know, does it actually work on patients that is not in the training set? And if it works, how many practice actually achieve that? And if we want to improve it, what are we expecting? Then the next one, now I understand that from the doctor's point of view, dollar is never in the objective function. And if you look at our equation, dollar is never there. On the other hand, it's a huge amount of dollar that we are talking about with the 18% of the GPD is on healthcare, and 65% of that GPD on healthcare belongs to this group of patients, right? So you would like to know, if I'm going to improve these, what am I expecting? So this is just really return on investment, the impact, the quality outcome, and analyzing it so that we can actually make a case in front of the doctors and all the providers saying, yes, if you make changes, this is what you see. And then we have the implementation, the actual implementation, the change management, and also evaluations. And I have to say that I think Dr. Egan really is the heart of the implementation. And I will show you what is happening is that they are able to really work with these sites and get the work implemented. So the challenges here are multiple folds. And of course, our first step, the first step for us really beyond IRB is to be able to get the data. And I think that was really a challenge, like the first 9 months is getting all the data, making sure they all connect together, all the terminologies, and also across the sites, and then do text mining. A lot of these are new because text mining has never been really looked at such a huge amount of data. And then we cluster and understanding that lab test results, even for the same type of disease, could be different. People come in differently at different time, the measurements is different. How do you really understand them together? Then you do large-scale classification analysis, and truly, how do you manage missing data versus those data simply is not there, right? For example, if I come in, I have every month measurement of diabetic glucose level. But another patient come in, all that they have is maybe every 3 months or once in a while they have those information. How do you use those in the most effective way so that you don't just delete all these patients because they are all important? And then dealing with the evolving data, I think my students really do appreciate me mentioning that. It's the first 6 months when we first get the first set of data. We are very excited. We start building the script and running everything. And then Dr. Egan sent us an email saying, by the way, Dr. Lee, we got more data. And all of a sudden, the students really jump and say, okay, you mean we have to write the code again? I say the idea is write the code so that it is automated, right? So I think when we first write the code, it was really like we write the code really designed for exactly those data. And then as we keep getting more and more data, then we have to automate that. And that's really, really important. And the continuous learning is truly is we provide the data and the results to the clinical setting. They have the implementation results. They feed us back the results, right? So that's the continuous learning. So the learning part truly is the machine learning as well as the learning on the ground for the implementation. So the first innovation, as I mentioned, is really connecting all these data together. And a very difficult concepts to try it, and we use really a lot of the powerful methods. And what these relates to, if for those of us that are really mathematical oriented and computer science oriented, is a huge amount of graphs, connectivity, redundancy checking, similarity checking in computer science, and being able to do all of these things, and at the same time being able to pull things out rapidly so that you can actually really understand, are you doing the right thing? This system can allow for rapid clinical trial. So if you are interested in certain type of patients, you can pull those patients out rapidly across all the sites, and that's really powerful. And then, of course, the graph is gigantic. So people like to ask, what is big data? And I say here, we just count even just the index itself. No content is 11 gigabyte so it's a huge amount of data that you're talking about, connecting all of them together. And this is really the first attempt connecting all the electronic medical records over even just a healthcare system of 10 hospitals. This is 737 sites, as Dr. Egan says. We have more than those, and almost close to, I'm sure it's more than that many clinicians. And so you connect all of these. Basically, you have really like a dictionary of seas of patterns and stuff. Of course, you can experiment lots of things in it. So this is how it works. And this is the CCI. So this is the Care Coordination Institute, where they funnel us the data, in different sites. And so we got the diagnosis, we do text mining, and then all these terms that is being connected together, we can connect all those patients, and about 75% sometimes is being able to map to the standard SNOMED-CT, and the rest of it really are new. And that, from the doctor's point of view, is another way of innovation, is for those terms that have not been really identified yet in the medical field. Can you give us a terms of different things? I think it's really interesting. We actually give some terms to connect things, and we send it to Dr. Egan and his team, and he will say, yes, this is good, this is great, and how do you connect them? And then some of this, no, this is not right, and this drug means something else. So it's a lot of learning part there. And so we do the same thing for laboratory tests, and do the same thing with medication. Unbelievable medication. Sometimes the word only have exactly one letter that is different. It is really hard for us to know if it is a typo, or if it is the same drug, or if it's two different drugs. And again, that's the learning part where we need the clinician to help us, and then the procedure. So all of these components, and plus all the clinical notes, are part of the analysis. So in the second part is dealing with all these heterogeneous type of data, and trying to really figure out, how do we manage? Now we got all these patient data. We are really happy, but how do you really deal with all these lab tests that are different? And to show you an idea here, is that you can say, look, I have 2 time series data, and I want everyone to be really measuring the distance at the same time, and then see the difference and see if there's any similarities. Or you would do the nonlinear, what we call elastic alignment. Elastic alignment allows you not to really look at the timeline, so important, but to look at the trend of these individuals over a period of time. And so that becomes really very significant in terms of the result. And mathematically, there's a lot of mathematics to it, and we have like 2 papers related to that. And then we do multi-level clustering analysis. One of the things about clustering analysis is rather difficult is that as you do all these clustering analysis, you start to measure how you differ from the centroid, right? But centroid may not be what you're looking at. You want to look at the global differences across. And I have very little time, and I'm going to go rapidly, and because I really want to get into the implementation. So the innovation of the machine learning is that this is the one machine learning system where it has all the features that other systems don't have. Mathematically, it was really difficult to prove them. It took us a few years to really come up with all these key features, why, and prove that it's universally strongly consistent. It means regardless of what sample size you have, in different groups, it will always converge to the base optimal. So that means you can deal with imbalanced data rapidly and beautifully. I will skip the math. And I want to show you the results. And so, very interesting. So these are the diabetics result, cardiovascular patient and hypertension in the cohort. And if you look at it, 0 here means that they have only one disease, just diabetics. And then the others are like how many, all these multiple conditions, all these diseases, you see the distribution look quite similar. They have it's shocking to me because when we actually plot it, we plot it without really knowing that exactly how many diseases each of these people have, and they look very similar. And so this one, we run our in-house result and compare that with 24 others, well-known one. And what you see is exactly some other methods truly were really handicapped by the imbalanced data. And we choose only 6 particular features. And I think this is really the beauty, is that what we have shown is that you can actually, let me see if I could be so brave to use the pointer. You can see aspirin, you can see asthma. You can see we pick out the features that are coexisting conditions, right? So we are not looking at just one disease at a time. We're looking at the cohort of patients and key features that tells you exactly what the outcome is. And so the outcome with the mapping features add up like about 25,000. We actually improve the good outcome prediction quality. And then this is the results for hypertension and for cardiovascular disease. Again, each of these correspond to the rule, and then you can see, very interesting, the respiratory symptoms. And so this is cardiovascular disease, but yet it shows you how coexisting conditions, right, multiple conditions, actually predict the outcome. And so I think this is really important, is that it gives us the ability to really predict and compare to the PET smear results, which is 70%, and that's a standard really used in the clinical setting. Our results is really very significant. And the benefits to the patient is enormous in terms of the being able to really get good results and economic impact. So I think I do want to make it clear is that these are the global worldwide, and this is the number of people infected, and this is the dollars amount. Within the United States, this is really shocking, and Dr. Egan really is very passionate about it. Is hypertension is not the cause of death, but complication is. And that's like, if we implement our results, this is the savings that you're going to see. And this is, like I say, truly is an estimate of what the savings is if we only have 50% compliance. And a lot of savings is really reducing the deaths because of So I do like to give Dr. Egan at least a minute to talk about the implementation he has in the site. And this is in the safety net hospital, where we implemented in 3,000 diabetic patients and also about 2,000 of the type 2 diabetic patients, and with really good results. And this is in the safety net hospital. And Dr. Egan is going to talk about the implementation at the network level.
Thanks, Eva. So I've been working with physicians since 1999 on quality improvement, so 20 years. We've seen a lot of improvement in South Carolina. We went from 50th to 33rd nationally in cardiovascular disease across the state, but then stabilized at 33 to 36 for the past 7 or 8 years. And so we're looking at a new way of managing hypertension that might be more successful for folks. So just in brief, started in 1999, here we are in 2019, and Eva got the database prior to that most recent. But our strategies are to keep things simple because cost and complexity are the barriers to effective dissemination. And so we've tried to keep things very simple, evidence-based medical care, access, use of that, and evidence-based lifestyles. This is what we did. Now, these were a fairly motivated group of clinicians. They were managing about 800,000 patients. We looked at those with hypertension, hyperlipidemia, and you see the improvement in hypertension, hyperlipidemia. Let me just move to this. It's a 3-step program, measure accurately, act rapidly, and partner with patients. We give every month the clinicians in the clinics their scorecards, so blood pressure controls at the top. Then the accurate measurement of blood pressure, what percentage of patients. Now each individual or the clinic is the black caret at the top, and the comparator group is the light caret at the bottom. And so if the blood pressure is confirmed to be high, how often do they intensify therapy? What's the average number of medications? We're trying to get to 3 for the uncontrolled hypertensive. And if they're partnering effectively with patients, the systolic blood pressure falls more. 6 months blood pressure control in these are underserved clinics with 20,000 patients, improved 10%. A lot of quality improvement programs are short term, but you see over 90% of the gain is sustained. And this is the model that Eve and I will be using. I'll go through this quickly. It's a matter of getting the data, synthesizing it, getting the best view if we can of the patients, doing the analytics, finding the efficient places to intervene, translating that into an intervention model, actually intervening, initially in small ways, limited clinics, but then broad implementation. Each cycle we get new data, it goes back into the analytics phase and continues to drive quality improvement. The goal is to turn that cycle in 6 to 12 months versus 5 to 15 years. So I'll stop there. We're a little over time. Thank you.